I mentioned broad spectrum antibiotics, and many antibiotics fall under this category. When we talk about a broad spectrum antibiotic, we talk about two forms of those antibiotics. They can be either bactericidal or bacteriostatic, and our book discusses this on page 66. Make sure you look at the memory jogger at the bottom of page 66 because it gives the definitions. But bactericidal, as I'm sure you can figure out, think of homicidal, suicidal. Bactericidal is a substance that kills bacteria, and it works fairly quickly, just, kills them flat out like a squirter raid does on a roach, just, kills bugs dead. Bacteriostatic, on the other hand, it does not kill the drug flat out. It limits a way in which the drug can work properly. So it makes the drug weaker and it makes the drug unable to reproduce. So it's not going to work quite as quickly. And some drugs have bacteriostatic actions in smaller dosages over a shorter period of time. Other drugs are bactericidal in larger dosages over a longer period of time. One of the most important teaching points that you are going to have to remember, and I'm telling you right off, this is teaching point number 1, write it down. It's not in red, but it ought to be. So circle it, highlight it, whatever. Antibiotics do not work on viruses. That is why right now at this particular time, we're having such a time with this novel coronavirus, this COVID-19, because antibiotics don't work. And that's true of colds. That's true of flus. Any kind of viral infection, an antibiotic is not going to do anything for it. Now, the exception to using an antibiotic for funguses and viruses occur when a secondary bacterial infection is present. Notice this is also in red. You will see it again. What happens a lot of times is that a virus attacks somebody. Their immune system is occupied with trying to respond to this virus and take care of it. And the body sort of becomes slightly weakened because the immune system is occupied with this virus. And so that allows a secondary bacterial infection to occur. So an example of this would be a person who gets the flu. They're very sick, they're very debilitated. It's almost like their defenses are on one side of the wall, leaving 3 sides of the wall unprotected, and strep sneaks in. Strep is a bacterial infection. So the person notices that, they felt pretty crummy for a week or so because of this flu, and all of a sudden they spike a fever again and have a very sore throat. When they go back to the doctor, a throat swab is done and strep is present. Did the flu cause the strep? Not directly, but the immune system was somewhat compromised because of the influenza, and the strep was able to take over, whereas before the patient might have fought it off. So that's when you would see somebody taking an antibiotic at the same time that they are recovering from the flu because they have a bacterial infection. Otherwise, it's not going to do much good. Now, a lot of doctors historically have had patients come in with viral infections, and they figure, well, can't hurt, might help. And especially when mamas are worried about their babies, they feel good if they leave the doctor's office with a prescription in their hand. So for years and years, doctors have just kind of given a broad spectrum antibiotic to any patient, even when they think it's just viral, just to kind of make them feel like they're doing something. Thankfully, that attitude is changing, and many doctors will not routinely prescribe an antibiotic unless they know that they're dealing with some sort of a bacterial infection. Now, we use these broad spectrum antibiotics for a large number of different pathogens, and each antibiotic that we're going to cover in our textbook is going to tell the various pathogens that the antibiotic will be effective for. Now, how do we know what antibiotic is effective for what pathogen? We do have some tests that can determine that. And one test is to determine if a pathogen is gram positive or gram negative. that's sort of a generalized test. There was a scientist named Hans Graham, and he discovered that some pathogens have a lipid layer that responds to dye and others don't. So if you dye a culture and the bacteria takes up the dye and turns purple, you consider that a gram-positive pathogen, and you know that there are certain antibiotics that work for gram-positive pathogens and some that don't. If the dye is rejected and the pathogen stays kind of a pinkish color, you know that it's gram-negative, and some antibiotics are going to work for that and some aren't. So in that way, they can sort of separate that and at least rule out some antibiotics being effective. The best way to determine what antibiotic is needed for what pathogen is to do a culture and sensitivity. And the healthcare provider orders a sample of sputum or urine or what have you, puts it on a slide with a particular medium where pathogens can grow, and then they see what shows up. And they'll look at it after 12 hours, after 24 hours, 36, 48, and they see what pathogen comes up, and then they can test with small samples of antibiotic to tell if a pathogen is resistant to that antibiotic or sensitive to that antibiotic. And I even saw one facility where I took students where it would not only, the lab would not only send up a report of what drugs were or what pathogens were resistant or sensitive, but it would also display little dollar signs after it. So a healthcare provider could look at that and say, okay, well, it's sensitive to these 3 antibiotics. However, this one is on the $4 med list, while this one is extremely expensive. So we'll start on the cheaper one, see if that takes care of it, because we know this patient can afford it, and go on from there. So that's really the best way, but so many times to save time, when a person stops by the clinic, they don't want to go through the hassle of doing a culture and sensitivity, or they do it and they let it grow, but in the meantime they order a broad spectrum antibiotic just to cover it, just in case. So that can be beneficial in some ways and not helpful in others. We know that the National Patient Safety Goals have determined that pneumonia, for instance, responds best if a person is covered by antibiotics within the first 4 hours of coming to a hospital. And so sometimes that doesn't leave time for a culture and sensitivity to grow properly and be tested, but they want to get a jump on that pneumonia before it gets worse. So it's not a perfect science by any means, but right now it's all we have. Drug interactions are individualized according to the pathogen or the antibiotic that's given, and food interactions depend on the individual drugs. And we will talk about drugs that, some that respond with some foods, some that don't, some that need to be taken on an empty stomach, some that can be taken on a full stomach. And so it just really varies. Once again, adverse reactions, know these. Superinfections can be caused by antibiotic overuse, which is a big problem right now. That's discussed on page 66. Organ toxicity can affect a number of different organs, and then cross-sensitivities or allergies. They're most common in penicillin and sulfa antibiotics, but any antibiotic, like any medication, can cause sensitivity reactions. Nursing implications for basic broad-spectrum antibiotics and patient teaching are covered in our textbook on page 68. That's just some general information. Make sure you read those general teaching points, box 5.2 on page 68. And on page 67, box 5.1, general nursing implications for antimicrobial drug therapy. I'm going to stop this video now, and I'm going to post a video called Antibiotic Resistance that I want you to watch because it kind of explains what we're dealing with some of these antibiotics.